Hi, this is Dr.Nilesh Kumar, and today we are going to discuss the hydroprocedures that go beyond hydrodissection. Often we come across situations where the BSS, whatever you use, is very beneficial. So this is a case where we have matte intumescent cataract and we have to perform a double rhexis, but we have to decompress. Usually what we do is we do irrigation and aspiration and snuff out all the extra cortex to decrease the pressure and then do a double rhexis. But what you can do is just press the lower lip and create a flow of BSS, and you can see how the cortical fibers get loose and come out, and then you have a free floating nucleus, and then you can just snip it with a micro scissor, and then using a Haldipurka forceps you can do a double rhexis with ease, and you are very safe to perform your phacoemulsification in a beautifully 5.5 well-centered rhexis. Now this is a second situation where we often see a small piece of cortical fiber or a epinuclear plate which does not enter into the suction probe. So what we have to do is to express it out, but it often doesn't come out very easily, and for that what we can do is stop the irrigation so that it gets free, and then when we press the lower lip of the main incision, it just comes and gets stuck into the main incision. But now as you can see that it is not coming out, so what we can do is grab a McPherson forceps and try to grab the small piece and pull it out and stop the irrigation. Now another thing is to hydropolish the posterior capsule. Now we have special sand blasted irrigation cannula that can be used for hydropolishing the posterior capsule, but you can see a very easy technique. You can use your normal irrigation cannula and just press the lower lip and create a flow just as you created in the intumescent cataract, and just angle your flow to the base of the cortical fiber attachment, and you can see how the posterior capsule is now clean and shiny, and very beautifully and very elegantly you can place your IOL in that shiny bag and give your patient the best outcome possible. The next case is hydropolishing of your anterior capsule. These anterior capsular fibers are quite sticky. They don't come off as easily as you saw with the posterior capsule, and the problem with the problem in polishing the anterior capsule is that the port of your suction cannula is above, and it directly grabs on the anterior capsule and it tries to pull it out, and you can have a zonal dialysis, so you have to be very gentle in performing this. And in such cases what you can do is create an irrigation flow, and then you can loosen these fibers and take it out. Right now what I am doing is now I stop the suction, the power, and then I just irrigate with the fluid and try to loosen it up as much as possible, and polish with the same irrigation cannula, and you can see a lot of fiber now starts flowing out. So this way it becomes very safe. The zonal dialysis chances go down. Now what we usually do hydroimplantation in the cases where it is the iris is nicely stable and the pupil is dilated, but in these cases where the iris is prolapsed from all the ports, and you can see from the suction port it is coming out, from the main port it is coming out, and when we draw the irrigation it is coming out. In such cases what you do, just gently take your irrigation probe, get the iris free from all these ports, insert your irrigation cannula, stop the flow, start inserting your IOL, so the IOL is filling the port and no fluid is leaking out. In such case the iris prolapse gets minimized, but as luck had it, in this case I had an IOL flip, but nothing to worry about. Just when you know that when you have to stop and when you have to start the flow, you can easily flip it out. You just stop the flow, flip your IOL, and then restart your flow, and then just place it behind your iris into your capsular bag, and nice and easy. Now hydroimplanting IOL in cases of SICs is also possible. What you have to do is a bimanual irrigation aspiration, clean out everything, some hydropolishing I did, and then the polishing of anterior capsule also slightly. And what you have to do is just start your irrigation, take your 3-piece lens and just dial it into the nucleus. When you have a good valve action on your main wound, you can just dial it in without much ado, and you will have a well-centered and well-placed 3-piece IOL in the back. So hydroimplanting in SICs is not as difficult or as alien as it may sound if you have a good scleral valve dial. Now moving on to next case, you have hydroexplantation of BX ring also. Now how to do it and when to do it and why to do it. So in this case what I do is I just go and pull out entire BX, and you see how it starts spinning. It's not a good thing to do, it might lead to endothelial loss, but now I am in this situation, and I am in this situation because I thought that in toric IOL I might need to do hydroimplantation, and then I have to hydroexplant the BX ring. So that spinning was not good. So what I did in the next case was to disengage the BX from all the sides, and I never left it throughout the procedure. And you see how traumatic it is for the iris. You can see a lot of iris pigment attached to that BX ring. It's not a good sign to see. It might lead to inflammation later also. So now I improved on my technique, and you can see in the third part what I do in third attempt. I just go inside with the BX or forceps that comes along with the BX that is supplied by measurement devices, and no financial interest in that. And I just disengage one of the flanges, and that way you can see 2 apices are free, and I hold the BX from one of its apex, and then I disengage entirely and then try to pull it out. You try to hold it from the apex that is near the main wound, and that's all. That's what we can do all beyond the Hydroprocedure. Thank you for your kind attention.